Hi everyone, welcome to my next YouTube video. This is for PYC3702. I'm a third year UNISA student. Starting this one late, so it's probably only going to be useful for people in 2023. We're looking at depression, bipolar, and suicide. Alright, so let's get started. Oh, and don't forget to like, subscribe, and share if this helps you. All right, let's go. All right, so depressive and bipolar disorders are both classified as mood disorders, and they are associated with an increased risk of suicide. Of course, we all go through times of feeling dreadful, but when is it a disorder? It becomes a disorder when it significantly affects your ability to function and your well-being. Also, when those negative moods continue for days, weeks, or months, when they occur for no reason, not because your life is really hard, and there are extreme reactions that are not explained by circumstances. Okay, let's run through the symptoms of depression. Okay, what is depression? Depression is a mood state characterized by sadness or despair, feelings of worthlessness, and withdrawal from others. So, depressed mood, sadness, emptiness, worthlessness, apathy, and hopelessness. Depressed cognition, pessimism, guilt, difficulty concentrating, negative thoughts, rumination, which can make things worse. Rumination is like thinking again and again and again and again about your problems, but not coming to a solution. Okay? Ideation, suicidal ideation, maybe feeling like a burden or unwanted or worthless. All right. Behavioral symptoms of depression. Social withdrawing, crying, low energy, lethargy, lowered productivity, agitation, poor hygiene. Physiological symptoms. Appetite and weight changes, either eating too much or too little. Sleep disturbances, either sleeping too much or too little. So that would be hypersomnia or insomnia. Aches and pains. In some cultural groups, these are the main symptoms that are reported. Loss of sex drive. Okay, symptoms of mania. In bipolar disorder, people swing between mania and depression. There's two levels of mania. There's mania and hypomania. So mania is characterized by a pronounced mood change, extremely exaggerated activity levels and emotionality that impairs normal functioning, giddiness, euphoria or hostility, irritation, agitation, may involve psychosis, may require hospitalization, very easily apparent to others. Hypomania, on the other hand, is milder. So a person may show more energy, they may feel self-importance, expansive or irritated, easily distracted, creative, having lots of ideas, impulsive, poor judgment, risk-taking. So this may be apparent to people around the person, and they may still be able to function in everyday life. Okay, they also talk a lot and take over conversations. So let's look at a manic or hypomanic mood. An elevated mood, extreme confidence, grandiosity, irritability, hostility. So there may be a lot of fighting going on. The person can get very tiresome, and then you get a lot of conflict. Emotional lability, so labile, mood swings. All right. Cognition. The person may be disorientated, racing thoughts, often thinking about what they're going to achieve and goals and dreams for the future. Flight of ideas. In other words, the person changes topics, gets distracted with new thoughts, and makes irrelevant or illogical comments. Decreased focus and attention. They may fail to recognize that their behavior is inappropriate. Creativity, poor judgment, pressured speech, rapid, loud, difficult to understand, difficult to get a word in edgeways. Behavioral, overactivity, rapid or incoherent speech, impulsivity, uncontrolled spending, leaving jobs, getting promiscuous, doing all sorts of exciting things. In extreme mania, the person may rant and rave, move constantly, and experience psychotic symptoms such as hallucinations and delusions. So they may become a danger to themselves and others. The physiological symptoms of mania are high levels of arousal, decreased sleep, maybe days without sleep, and increased sex drive. Okay, so evaluating the symptoms. Now, sometimes people have manic symptoms in their depression, or they have depressed symptoms in their mania. So this is called mixed features, and it can make it confusing and difficult to evaluate. Okay, so normally people go through a careful checklist. So they cover the behavioral symptoms, the mood, cognition, and physiological symptoms, frequency, duration, seasonality, intensity, and other factors that may be causing symptoms. For example, a thyroid imbalance, or use of alcohol or drugs, maybe illegal drugs or legal drugs. Okay, so depression and bipolar have quite different pharmaceutical treatments, so it's very important to distinguish between them very clearly, and also to reassess, because people sometimes move from one state to the other. Okay, depressive disorders, there's a little video of 5 types. Then our study guide says 8 types and then lists 7. Now in this list, we do need to remember to look at number 4, which is disruptive mood dysregulation disorder, because they like to catch you out with that one. If you don't have an updated textbook from the Sue family, or you've skipped over the study guide, you will be caught short in the tests. All right, so remember disruptive mood dysregulation disorder. So we're going to look at these quickly. Major depressive order, persistent depressive disorder or dysthymia, premenstrual dysmorphic disorder, disruptive body dysregulation disorder, and then we have other kinds of depressive disorders which we don't need to worry about too much. Okay, here's some key vocab. Apathy, lack of motivation and drive. Anhedonia, the lack of ability to be happy or take pleasure in things, a dreadful feeling. Okay. Lethargy, lack of energy in general. Self-denigration, denigration from painting black. Okay. So putting yourself down. Catatonia, abnormality of movement and behavior. So this may come from schizophrenia. It may involve repetitive or purposeless overactivity or catalepsy, resistance to passive movement, and negativism. So a person might just freeze in a funny position. Okay. Melancholia, deep sadness. Rumination, thinking again and again and again about problems without coming up with solutions or action. Unipolar disorder, that's another word for depressive disorder. Okay, major depressive disorder. So this is for at least 2 weeks, no mania or hypomania. You must have severely depressive symptoms that negatively affect functioning nearly every day for most of the day for at least 2 weeks. So that's a very short time, and then you can be diagnosed with a major depressive disorder after 2 weeks. Okay? Consistent pattern of depressed mood, feelings of sadness or emptiness, loss of interest or pleasure in previously enjoyed activities. In addition, at least 4 additional changes in functioning. Significant change in weight or appetite, sleep pattern changes, restlessness or sluggishness, low energy, feeling guilty or worthless, difficulty concentrating or making decisions, possibly suicidal behavior or recurrent thoughts of death or suicide. Okay, the lifetime prevalence of major depressive disorder is 14 to basically 20%, 1 in 5 people. Far more common amongst women, so that is very common. Can begin at any age, but most often in the late 20s. Okay, suicide risk. Suicide is a risk for anyone with major depressive disorder. It can be, if you're feeling hopeless and impulsive, you are particularly at risk, and particularly if you are being rejected by people you care about. Okay, and especially if you then go on to get intoxicated and you lose your judgment, you lose your self-restraint under the influence of those drugs, you are more at risk. Nearly a third of the people with major depressive disorder also have substance abuse problems, which increases the risk of suicide and also makes it much harder to help that person. Okay? Because it's complex. You help the depression by giving people tools to be proactive, and that goes into the substance use disorder. Then they go back to passivity, and that feeds into the depression. Okay. Grief and chronic long-term depression is also a risk factor for suicide. Okay. So let's compare and contrast major depressive disorder with grief. Okay, so with grief, the person may feel emptiness and loss, but with major depressive disorder, they are unable to anticipate happiness or pleasure. They stay down. It doesn't change according to what you're thinking of depressive. But with grief, obviously, as you think about your loved one and as you think about your loss, and if only you'd done things differently, that is what's going to trigger your feelings, and those strong negative feelings are going to diminish over time, and they're going to come in waves with positive feelings in between. Okay? Major depressive disorder, it's all going to be turned inwards, pessimism, and thinking about yourself a lot because you're the one that's in pain. Grief, obviously, you're going to think about the person you've lost a lot more. And if you're going to think badly about yourself, it's going to be relative to what you should have done, could have done, your relationship, and what you've lost because of what you did wrong. Whereas with major depressive disorder, it's more global. It's more about what a terrible person I am. Okay? How dreadful I am. Okay, if you're thinking about dying because you've lost someone, it's because you're thinking about joining them. Because they were what drove meaning in your life. If you're thinking about ending your life because you're suffering from major depressive disorder, it's more likely that you're going to be feeling worthless, undeserving, unable to cope. Okay, let's look at persistent depressive orders. Persistent is the key word, meaning long-term, 2 years or longer, okay? Chronic depressive symptoms, most of the day for more than half the time, for 2 years or longer, no more than 2 months symptom-free. So it becomes persistent, it does not leave, okay? Dysthymia. So you need at least 2 of these. Hopelessness, low self-esteem, poor appetite or overeating, low energy or fatigue, unable to concentrate or make decisions, sleeping too much or too little. Some people, this never changes. They have it for life and treatment doesn't seem to help. Absolutely dreadful condition to suffer from. Extremely unpleasant. Okay, let's look at premenstrual dysmorphic disorder. Okay, right, a lot of people battle at premenstrual time of the month, but in this case there is significant inability to function and disruption of life and well-being. Okay, so there's serious depression, irritability, and tension. At least 5 symptoms, and at least one of them must involve significantly depressed mood, mood swings, anger, anxiety, tension, irritability, increased conflict. Possibly also difficulty concentrating, social withdrawal, losing energy, food cravings or overeating, insomnia or excessive sleepiness, feeling overwhelmed, bloating, weight gain, or breast tenderness. Okay, but not at the normal level that most of us go through, at the level of really losing functionality. Okay. So now we've got disruptive mood dysregulation disorder. This is a depressive condition for children, but it doesn't always manifest as clear signs of depression as such. Okay? This was only added to the Dsm-5 in 2013, so if you've got an older SU, you might not have it in your textbook. Okay, age 6 to 18 must start before age 10, so it's not around adolescence that it starts, with persistently irritable or angry mood and frequently losing their tempers out of proportion to the situation. Okay, outbursts 3 or more times per week and in multiple settings, so it's not being triggered by some horrible situation at school or at home, etc. It's more prevalent amongst boys, and it is associated with autism, okay, or people on the autism spectrum disorder range. Okay, so let's look at prevalence. Okay, all right. Lifelong prevalence of 19% in the United States. It's the second leading cause of disability worldwide. You can actually get a disability grant for being depressed. It's a terrible condition. Okay, 15% of people fail to improve with medication. Some of those people may be failing to improve because they have bipolar disorder that hasn't been diagnosed properly. But then there's also, this is in one place in the textbook, and another place in the textbook it goes on about how the medication is basically roughly equivalent to placebo in many cases. So we'll look at that now. Okay. So what triggers and what causes? What is the etiology of depressive disorders? Environmental factors and hereditary factors. Okay. Let's run through this. Biological dimension. Neurotransmitters, low serotonin, norepinephrine and dopamine are associated with depression. It does definitely run in families, higher in female than male twins, associated with a specific gene, the 5-HTT-LPR. If this gene is triggered by childhood stress and trauma and unhappy childhood, then the genes get expressed as depression in adulthood. Cortisol and stress. Okay, when the HPA, the hypothalamic pituitary adrenal axis, is dysregulated and overactive and excessive cortisol is produced, this causes depressive symptoms in adolescents and adults. So your childhood can set you up for all sorts of problems, including major depressive disorder. Okay? Brain changes. Stress-induced changes in the hippocampus. Reduced neuroplasticity. Some people, it's circadian, especially like in the Nordic countries where it's dark for many months of the year. This may trigger quite a serious case of depression. Lack of vitamin D is actually also implicated in depression, and insomnia doubles the risk of developing depression. This points to a circadian issue. Psychological dimensions. All right, so there's ways of thinking about yourself and the world that can really make you quite unhappy. Okay, so if you've got social isolation and rejection, this is a major trigger of depression. We are social beings. This is why solitary confinement is such a terrible punishment for people. So stress, loss, and a positive feedback loop of social withdrawal and depression can make things a lot worse and perpetuate it. Okay? Some people see depression as a cognitive condition, disturbed thinking, so that you are thinking wrong, you make yourself deeply unhappy. Correlated with pessimism and negative perspectives, global thinking, so that you think that every problem is because of the whole world, okay, causing hopelessness and pessimism. Can't see the positives, you don't believe they're real, you ruminate rather than problem solve, and you talk with other people, you ruminate with other people. Another idea is learned helplessness, attributional style. Okay, when we think we don't have any control over what happens to us, so it's negative, internal, because of me, global, across space, and stable across time. It's not going to change. Once you're seeing everything as negative, internal, global, and stable, then this can easily cause overwhelm and then depression. Okay, so a lot of what people do who are helping people change their thoughts to help their depression is they look at, okay, it's not personal, it's external. It's better if you see it as unstable, it will change, this too will pass. And specific, it's just here in this little town, in this little job, in this little family situation. As soon as you change the situation, this too will change. Okay. Negative self-concept, people seeing themselves in a poor light, can give rise to and perpetuate depression and deep personal suffering. Okay, the social dimension. All right. Severe acute stress often precedes the start of a major depressive episode. It's again linked to cortisol, so major stress fries your circuits and can lead to major depression. People who've been through warfare also go through this feeling of anhedonia, everything turns grey after a certain level of stress. Chronic stress, also significant, which is why particular jobs, the highest ratio of depression is actually, and risk of suicide, is actually real estate people. Can you believe? Isn't that strange? Okay, once you've been depressed, you are vulnerable to being depressed again, childhood maltreatment, social rejection, and then also once you're depressed, you're not fun to be around, and this can make it even more stressful because your social ranking, your social capital is going down all the time as you are depressed, as you fail at life. Okay. Right. Culture. How you see it, how you name it, how you frame it is very culturally specific. Affects how you're going to treat it and the outcomes. Also suicide risk and your therapeutic relationship. Okay, discrimination, yet another trigger and correlation with depression. Sexual orientation, if you're discriminated against because you're LGBTQ. This is a dreadful stressor and can be correlated with depression. Also, being female and sexual abuse both correlate with depression. Treatment. Okay. Biomedical treatments. Medication works by increasing the availability of norepinephrine, serotonin, especially the SSRIs, Prozac is the most famous one of those, and dopamine. Okay, many people take antidepressants, some parts of the world for years. Okay, they do help with severe depression, although they are correlated with an increased risk of suicidality in people younger than 25. But actually, if you actually do the research, you'll find that exercise and omega-3s and sunlight seem to be even more effective than antidepressants for moderate to mild depression. Okay. Right. Some treatments work by resetting your body clock, and this can help for some people. Oddly enough, cold showers can help for some people also trigger the bodies to reset itself. Cold therapy. Brain-stimulated therapies. Electroconvulsive therapy, ECT. It's been used for many years. When people are desperate, they will be grateful for this, even though it takes away some of your memory and possibly some of your cognitive functioning. Okay? Quite a dangerous treatment, but still used to today because depression is so terrible. Vagus nerve stimulation, new therapy, but requires a bit of surgery. They've actually got to put a little implant in next to the vagus nerve to trigger it. Okay? Has had amazing results. Transcranial magnetic stimulation, less invasive, across the head with magnets. Okay? Everything is worth looking into if you have depression. Okay, psychotherapy and behavioral treatments actually help a lot. They work better than medication and have more lasting results. So behavioral activation, helping people to get back out there and find ways of having fun and socially connecting. Helping people work through their lives, their relationships, okay? Helping people change the way they think. Mindfulness-based cognitive therapy. Learning to be present and calm rather than stressing yourself out. Okay? Alright, let's whiz on to bipolar disorders. Very important to be diagnosed properly, not bypassed, because sometimes the depressive symptoms can mask the manic or hypomanic symptoms unless you question very carefully. 3 kinds. Alright, let's go through the Dsm criteria. There has to be a hypermanic or manic episode. Most of the day, nearly every day. Consistently elevated, expansive or irritable mood and unusual increases in energy or goal-directed activity. So you may have grandiosity, less need for sleep, pressured speech, racing thoughts with frequent topic changes, distractible, work, sexual and physical activity goes up, impulsivity. Hypomanic for at least 4 days, manic at least 1 week or more and requires hospitalization or very impaired functioning, possible psychosis. Okay? So there's 3 kinds, and this is the easiest way to remember them. That's all you really need to know. Bipolar I goes up into the manic, from major depression up into the manic. Bipolar II, major depression, but only up into the hypomanic. Cyclothymic goes dysthymic, so like minor, moderate depression to hypomanic. So it's like still in the middle, you're kind of functional, but life is not great. Okay. Right, some people have mixed features, remember? Mania in the depression, depression in the mania. Some people have rapid cycling, 4 or more mood episodes a year. Common comorbidities, anxiety disorder, 75%. ADHD, eating disorders, substance abuse, suicidal ideation with increased risk of suicide. Okay, there's a complex genetic basis, circadian rhythm seems to be involved, glutamate, neurotransmission in the brain seems to be correlated, traumatic brain injury can trigger this, and it can also trigger depression in and of itself. There's common genetic vulnerabilities with schizophrenia, so it's linked to schizophrenia. Okay, suicide. Now I whizzed through this, so we're just covering the essentials. Okay, up to 90% of all people who have suicidal ideation qualify as having a mental disorder, and mental illness is associated with the risk of suicide. 80% of people will signify, but not the other 20%, in some way to someone that they are contemplating suicide, either through what they say or what they do. But they may not share this with many people. Okay, so sometimes as a witness you feel like there was no indication, but you'll find that they did reveal to someone somewhere along the line what they were planning to do at some point in time. Sadly, this is not always caught. Okay, and sadly, it's not always possible to prevent. It's the 10th leading cause of death in the US, and amongst college students, that's us lot, 2nd leading cause of death, major risk. Mainly it's youngsters, adolescents up to mid-20s, and the elderly. Some people are just trying to escape their pain, they're not necessarily really thinking it through. And 1 in 25 suicide attempts ends in death, which sounds low, but if you think about more than 1 attempt, goes up quickly. Common characteristics: hopelessness, things will never get better, suicide is the only way out, trying to escape, painful thoughts and feelings, deep pain. Triggering events: fights, conflict, depression, hopelessness, anger, guilt, shame, being rejected, feeling like nothing is going to get better, feeling worthless, failing. Okay? So how do you help someone who is suicidal? What is needed is to reawaken and reinforce the desire to live, help the person expand their point of view, enhance social connection and support, and help the person develop more coping skills. Okay, and of course, there's no guarantee that you can stop someone from committing suicide. Sadly, but sometimes you can. Alright, so good luck, and I'll see you next week maybe. Okay, bye.